This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome everybody to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. For those of you who are new, I'm a Med-Peds trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh in the Paul C. Gaffney Division of Pediatric Hospital Medicine. You know, we've been coming to you since October of 2016, walking through the pediatric hospital medicine content specifications on this podcast, bringing you new material, and we have been coming out with a flurry of material lately to make up for the dearth of material over the past year, which I still apologize for. This episode, I have to give a special shout out, is thanks courtesy. We teamed up with the section on hospital medicine, newborn medicine subcommittee. So for those of you who remember that subcommittee who listen, this one is for you. Special thanks to Drs. Julie Kim and Elizabeth Simpson, who helped put this all together by contacting our very special guest to help us today. Today's episode, I just said, we are partnering with the Newborn Medicine Subcommittee. So we are going to talk about a newborn topic. Today's topic is an oldie but a goodie. It is management of newborns born at greater than or equal to 35 weeks gestation with suspected or proven early onset bacterial sepsis. This is the guideline from the AAP that came out in 2018. I'm very, very fortunate to be joined by our special guest today. So Dr. Karen Puopolo, MD, Ph.D., is taking her time out to join us. Dr. Puopolo is a neonatologist who specializes in neonatal infectious diseases. Dr. Puopolo received her undergraduate degree in physics from the Yale University in New Haven, Connecticut, and went to obtain her MD as well as her Ph.D. in molecular physiology from the Tufts University School of Medicine and Graduate School of Biomedical Sciences in Boston, Massachusetts. She completed pediatric residency and neonatal perinatal fellowship training at Boston Children's Hospital. She began her neonatal research career as a laboratory-based scientist investigating mechanisms of virulence in Group B streptococcus. More recently, her research has focused on the epidemiology of neonatal infection with an emphasis on risk assessment and antibiotic stewardship. In collaboration with Dr. Gabriel Escobar, she completed the Neonatal Early Onset Sepsis Calculator, which is a clinical decision tool that I'm sure you've all used based on multivariate risk models that have changed the landscape of term sepsis risk assessment. Dr. Puopolo is currently a professor of pediatrics on the faculty of the University of Pennsylvania Perelman School of Medicine. She's a member of the Division of Neonatology at Children's Hospital of Philadelphia and chief of the section of newborn medicine at Pennsylvania Hospital, and the first author of the guidelines we're going to talk about. So, Dr. Puopolo, thank you so much for joining us.
Well, thank you for having me. I'm really excited to be on a podcast. My oldest son runs a podcast in his spare time. So,
what's the name of the podcast?
It's Run Your Mouth. His name is David Melly, and he is not a professional runner, but he's a nationally ranked distance runner. And in his spare time, he hosts Run Your Mouth for Tracksmith.
Oh, I love the play on words on there. Well, there you go. We just got it on. Great. That's wonderful. So, Karen, we have to do our conflict of interest statements because we are a CME podcast. I will go first and kick it out to you. I have nothing to disclose.
I have nothing to disclose.
Well, that's wonderful. Now, Karen, this guideline, first, let's define what we're talking about with the guideline in terms of neonatal early onset sepsis, just for our listeners at home. And I'll say it because I know you know it, and then you tell me if I said it correctly. Early onset sepsis here we're defining as blood or CSF cultures obtained within 72 hours after birth, which grow bacterial specimen, pathogenic bacterial specimen. Is that right?
That is correct. Early onset sepsis can also be due to fungal organisms, but in term infants, that's exceedingly rare. And even in preterm infants, it's unusual. And there is one exception to that time frame. Traditionally, the Centers for Disease Control and Prevention have defined early onset sepsis due to group B strep as occurring up to 6 days after birth.
Up to 6 days, okay.
Yeah. But otherwise, the definition limited to cultures obtained less than 72 hours or less than 3 days after birth is there to distinguish perinatally acquired infection from hospital-acquired infection, particularly among preterm infants that may be continuously hospitalized past that. But for term infants, and for what most neonatal clinicians are concerned about, is you're concerned about the immediate sort of 1 to 3 days after birth, which is the typical birth hospitalization.
So, Karen, I always like hearing about what was the impetus of these guidelines. So we're going to talk about why these guidelines I find interesting. They're unique among all those I've read. But how did this one get created? What was the impetus behind this?
Well, as you know, being on an American Academy of Pediatrics section, the American Academy of Pediatrics takes seriously their role in looking at evidence, or lack thereof sometimes, and providing pediatric clinicians with both informations and guidance on a variety of topics. And in order to create a clinical report or a guidance document, there's a formal process at AAP. You can create a new one on a new topic like COVID or such, or there are many, many standing clinical reports that address common clinical issues in pediatrics. So I was on the committee for the fetus and newborn from 2014 to 2021. And during that period, the existing clinical report addressing this topic was up for renewal. So every 5 years, clinical reports either have to be reaffirmed, unchanged, or edited and rewritten. And the existing report, which was dated 2012, for whom the first author was Dr. Poland, Richard Poland, was up for renewal, and the committee voted to revise it.
Okay, well, it's pretty straightforward. This guideline is interesting. I've never seen one written that's like a choose-your-own-adventure guideline. You can be right in just about any direction you go. That's innovative. I haven't seen that before. I don't know if you've seen that before. Maybe I have missed it. But how did that come about as the model?
That was probably a sort of one of the second decisions the committee had to make in revising the standing clinical report. So up until then, the guidance on this topic had encompassed all babies. So one of the first things we did, looking at the epidemiology and what was known about this infection at birth, is we voted to split the current clinical report into 2 clinical reports. As you can imagine, those of us who are doing it were like, oh, good, double the work. Addressing babies born 35 weeks and above, we were really trying to focus on an infant that could be in a well nursery setting versus infants that really in most parts of the country are going to be admitted to a neonatal intensive care unit. So we made the cut at 35 weeks gestation at birth. And the reason we did that is not just because of the different settings in which these infants are cared for, but they come to us very differently. So the risk factors, the pathogenesis, the incidence is just so different between preterm infants and term infants that we felt like we really needed to do it justice and make 2 topics. And then when we turn to the matter of adjusting guidance for term infants, a lot had happened since the last report had been published. One is the development of the multivariate models that are the sepsis risk calculator. But another really was the recognition that antibiotics have their risks and their benefits. And there was certainly a greater consciousness over the past, say, 10, 15 years around that balance. So I think the other thing we realized as the committee looked at the evidence and debated what to do is when you have a disease in front of you, if you have cancer, you go and you figure out what type of cancer, and now we have molecular diagnostics, and then we look and we see, okay, you have this, and this is what should be done. You might be in a trial. to see if you want to do something innovative, but there's usually a clarity about that. But a lot of what this guidance document was addressing was risk assessment. And so risk assessment comes with risk acceptance. Clinicians need to decide at what level of risk a child who may be well appearing or may even be a little sick warrants a specific intervention. And the different approaches, the existing approach that had been advocated, which we renamed categorical risk assessment, the use of the calculator, and some evolving approaches that rely on serial evaluation, use the same risk factors. They're addressing the same infants, but they involve different activities in the birth hospital, and fundamentally, they involve a different acceptance of risk. And then the last thing that they address is the difference between being able to identify every infant at birth who may or may not develop this infection versus waiting for a child to manifest signs of illness. And the truth of the matter is when you start discussing this with clinicians, this idea of risk acceptance, treating you before you become sick, treating you only if you look sick, there's a lot of sort of philosophical approach that comes into it. And so I think the committee felt like we should just call it like it is and say each of these approaches has its risks and benefits and has its sort of upsides and downsides. We're going to tell you what those are. And we're going to tell you clearly that you need to look at your local structure of care, what your resources are in your birth hospital, and come together and make a decision about what you think is the best approach, because each of them are quite legitimate. They use the same risk factors. Their same goal is to keep the babies safe. One thing Gabriel Escobar taught me when we first started doing the work that led to the sepsis risk calculator is he said, current approaches have a risk acceptance. There is a number needed to treat behind what you're doing. But clinicians don't know what it is. They don't actually, there isn't a number put on it. People are not asked, if the chances are 1 in 200, do you think it's reasonable to give antibiotics? If the chances are 1 in 1,000, do you think it's reasonable to give antibiotics? And so the calculator puts it in front of you and does require that you look at that number and make a decision about risk acceptance. Maybe a long-winded answer, Tony, but I realized in doing the work that I've done, in speaking and having the privilege of being invited to speak at different settings and talking to clinicians all over the country, evaluating babies at birth for risk of early onset sepsis is a fundamental clinical activity that every neonatal clinician has to do for all 4 million births a year in this country. How you do it, what your supports are at your local hospital, what your options are if a baby gets very ill, are really different in different parts of the country. And those differences matter. And so I think in the end, as we worked through this, we thought it was most respectful of perinatal clinicians across the U.S. to lay it out and let folks think through what was the best approach in their setting.
It's remarkable. I mean, it's treating us like adults, which I really like a lot in that. And so for instance, we were partnering with the newborn medicine subcommittee, and I didn't mention this, but the reason this is happening is because the newborn medicine subcommittee talked to their leadership and asked for more didactic information, more specific lectures on these topics. And in our subcommittee, we have a wide range of types of hospitals. You have small community hospitals with perhaps less support. And maybe if they need to get to a tertiary care center, they're maybe 45 minutes or an hour away or sometimes longer. And then we have gigantic academic hospitals like the University of Pittsburgh or Children's Hospital of Pittsburgh, where the support is within seconds. And each of those places, exactly like you're saying, will need different things. They can't all operate the same. And your guideline really gives them that opportunity to pick what works best for them. I really did. I love the idea.
And I'll tell you, Tony, the only thing that the guideline really does say you should do is make a concrete decision. Write it down. Everybody at your center agree that this is what we're going to do. And to the extent that you can, keep track of how it works out for you. I think one of the most impactful things that I ever did is when I first started doing this work years ago in Boston at the Brigham and Women's Hospital. I was working with a third-year pediatric resident who needed a project to complete her residency. That person has become my long-term mentee, Sagru Mukhopadhyay. And I said to her, I think we had a local guideline informed by probably at that point, the CDC 2002 guidelines. And I said, Sagru, just look at all of the sepsis evaluations we did in term babies for a year and just tell me, like, why did we do them? Like, what proportion were done for this reason? What proportion were done for that reason? And then let's look at their white blood counts and just see how that worked for us. And we were amazed that that information just wasn't available. Like, what proportion were being seen because mother had a fever? What proportion were being done because mother had inadequate GBS prophylaxis? What was the catchment? Sort of the efficiency, so to speak, of each of those categories. And then the thing, of course, that really surprised us is we published this in Journal of Perinatology. Out of 1,000 some odd sepsis evaluations we had done in well-appearing term infants, the white blood count and the I/T ratio and the ANC had done nothing for us. It was basically looked normal by our local metrics for normal in almost all of them. Among the ones where it wasn't abnormal, none of them were it wasn't normal, nobody was infected. And of the 3 cases of culture-confirmed infection we found that year among well-appearing infants, they all had a normal CBC. So I have great respect for what you can learn from looking at what you do. I was really surprised, I have to admit. I thought what we were doing was grand, and it worked well. And I didn't recognize until we actually accounted.
And I can see shades of that early work in the white blood cell count section, this guidelines where you talk about, as newborn sepsis gets more and more rare, the white blood cell count and differential really becomes less and less helpful.
And I think we did not recognize that. We were doing what we thought was the right thing to do. We didn't question it. And, looking at what you do and keeping track of how it works out is instructive.
So can we start walking through these guidelines, Karen? I'd love to I want to start with the beginning, which is always a good place to start, for the pathogenesis and epidemiology, where you get into how Group B strep has changed. Would you mind talking about that a little bit?
Sure. So the pathogenesis of early onset sepsis for a term infant, you can think about it as occurring during the process of birth. Really different from a preterm infant, where some process of intraamniotic infection may be the whole reason you end up being born at 24 weeks. But for the most part, you think of a healthy pregnancy and an uninfected woman undergoing the process of labor and delivery. And during that process, there can be ascending colonization of the uterine compartment, and ultimately the amniotic fluid in the fetus with just normal maternal genitourinary and gastrointestinal flora, which is what colonize the vaginal and cervical compartments. And in some cases, those normal bacteria, normal and unpathogenic to the woman, can in fact transition into invasive infection of the fetus and newborn. And one of the things that makes this a complicated topic is that sometimes that pathogenesis occurs and is pretty advanced by the time the newborn appears. And so the newborn may appear in the delivery room sick because that pathogenesis has progressed. It may be that the only part of the pathogenesis that has progressed is sort of a heavy colonization of the fetus and newborn with what eventually becomes a pathogenic bacteria, like group B strep to the infant. And so the transition from colonization to invasive infection may be happening after birth, or it may have just happened. And so maybe the baby is bacteremic, but not yet manifesting symptoms of illness. At this point, Tony, I am going to interrupt myself and say that I keep using words like the woman, and I do want to fully recognize that that is a language that is traditionally used. Not all pregnant persons identify as a woman. And to the extent that that continues to mark my language, I do have to apologize for that. I will use the word mother after birth as sort of an all-encompassing term that does not have a gender association. So I think that the bacteria, which are the primary causes of early onset sepsis, have changed over the years. No one really knows why. In the 1930s, most infants were dominated by gram-negative infections that were really uniformly fatal. And it wasn't really until the 1970s that group B strep started emerging as one of the primary bacteria that caused neonatal early onset sepsis. And with the recognition that not all women are colonized with group B strep, came the idea that selective decolonization of the pregnant person may be a good strategy for ultimately interrupting that pathogenesis. Lots of different things were tried, and eventually it was clear that the most effective way of giving prophylactic antibiotics to decolonize the pregnant person, therefore interrupt the transmission of this bacteria from mother to child, was to give antibiotics intrapartum. And so in the world of intrapartum antibiotic prophylaxis to prevent group B strep, which, by the way, prevents other types of gram-positive infections as well as gram-negative ones that are sensitive to ampicillin, but that's rare nowadays. And the ACOG sanctioned use of antibiotics when there's concern for evolving intraamniotic infection, the overall incidence has thankfully gone down a lot. So anywhere from 3 to 4 cases per 1,000 live births in 1990 to currently we're looking at roughly 0.5 per 1,000 or 1 case in 2,000 solidly term infants in the 21st century. There is a little bit of difference in the incidence between, say, a 35, 36-week infant versus a 38-week infant. But for babies born greater than 37 weeks, the incidence of culture-confirmed early onset sepsis currently is 1 in 2,000 live births. And that's a great thing. But it also means that we are now doing a lot of activity to find very few infected infants, which again is great. About half of those infants will be symptomatic in the delivery room, and about half of them will present usually within the 24 hours after birth. It's rare to see the onset of early onset sepsis beyond 24 hours of age, but it happens. And, if you look just at group B strep, the most recent national data would tell you that something on the order of 95% of cases present by 48 hours after birth.
So that was the best discussion on this I have ever heard. So thank you. And I didn't know in the 30s it was primarily gram-negative organisms, and it changed in the 70s. I hadn't heard.
And in the 1950s, interestingly, Staph aureus was also a cause of early onset sepsis, which we don't see. And how group B strep emerged as this colonizing pathogen is a whole, we could spend a podcast, so I won't do that. But I will say that, currently, if you look at point prevalence, so you go and you check all the pregnant women in the country, about sort of 20 to 25% of them at any given time will be colonized with group B strep. It's not a good colonizer of the gastrointestinal system of a human adult, which is good. It does come and go. If you look serially at sexually active persons, women, over a year, so you sort of culture them, even pregnant, non-pregnant, every 3 months, then you're looking at any given time, 50 to 60% are colonized.
Oh, interesting. So one of the things I try to think of this as new guidelines from the perspective of someone who's been doing this a while. And one of the things people would potentially say is, why are we changing something that seems to be working if we may be overdoing it? And that you get into that in your antibiotic stewardship section, which was surprising to me. Well, I'm just going to read it out. So you basically say, for all the potential reasons a child could get antibiotics, what that results in that newborn period is 32 to 45% of all newborn infants get some antibiotic exposure, which struck me. I had no idea it was that high. If you had to ask me to guess before that, I would have guessed at 10 or 15%.
Well, when you start adding it up, what you find is this. So if, say, the roughly 20% of women who are colonized with group B strep get antibiotics at the time of labor and delivery, and the 3 to 5% who develop signs of intraamniotic infection get antibiotics. And then the other thing people don't think about is that about 30% of deliveries in this country currently are by cesarean section. And it is good standard of care from the perspective of the pregnant person to administer surgical prophylaxis antibiotics. So depending on where you are, that might be cefazolin, for example. Actually, here at Penn, they use cefazolin and metronidazole to get anaerobic coverage as well. And so you can definitely decrease the risk of post-C-section endometritis if you administer those antibiotics. But in fact, those antibiotics cross the placenta. They're given before the incision is made, and they cross fast. So the cefazolin, which is a beta-lactam antibiotic, will be in cord blood within 5 to 10 minutes of administration of the antibiotic.
Oh, wow, that's nice.
Yeah. And I actually don't want to make it up. I don't know the transplacental kinetics of metronidazole, but that is only local practice. So, so there's a lot of antibiotics given in this country around the birth process. And I don't want to criticize that hands down, right? There's good reason for all of it. GBS, it's been effective in preventing GBS disease in both the pregnant person and the baby, by the way. So GBS can be a cause of invasive infection in the pregnant person as well. Intraamniotic infection can be a life-threatening illness for, again, the pregnant person as well as the infant. And the prevention of C-section associated infection is super important. There's terrible morbidity and even a low rate of mortality associated with that. So that is good standard surgical practice. But it does mean there's a lot of antibiotic exposure before the baby has even been born.
And I like how you tie, and you admit that the associations are loose, not super tight, but how retrospective studies that have been done have shown early antibiotic administration in infants perhaps increases the risk of later childhood issues like wheezing, asthma, food allergies, IBD, and obesity. And you admit that that's a loose association, but how I read it was basically, if we can safely decrease the amount of antibiotics the baby's exposed to, why not try?
I think that's perfect, Tony. That's exactly the way to think about it. Antibiotics are really powerful tools, and some persons and some infants need lots of antibiotics, and they are the difference between life and death. That's fine. But we shouldn't be throwing them around thoughtlessly. Our group has contributed to this, sort of difficult to interpret retrospective studies, although we tried to do it very carefully, looking at some of the potential impacts of intrapartum antibiotics on subsequent infant and childhood growth. You affect the initial constitution of the infant microbiome with the administration of intrapartum antibiotics and neonatal antibiotics. You just do. That doesn't mean that's a terrible thing. But you do, and it's not surprising that there may be consequences. And again, just like you said, if this is what you have to do, do it. And if you don't have to, maybe we should not.
Yeah. I mean, it's like anything else. We do things, and if COVID's taught us anything the past 2 years, it's there are unintended consequences to well-meaning things, and we should keep an eye out for them.
My mentee Sagri has this great. She said this thing to me that I often repeat because it seems simple, but it was so profound to me. She initially trained in a low and middle income country before coming and training in the U.S. And she said to me one day, she said, "Karen, you can do the natural thing. The natural thing is fine. But you do need to understand that nature assumes that some newborns will die. And a lot of what we do in medicine does hijack nature for good purpose. We need to accept that."
I think that's very fair. I agree with her 100%. So, and then we get into, and I have to be honest with you, Karen, what struck me when I started reading these guidelines, because in our hospital medicine group, we do not practice newborn medicine. So, which is why I needed to partner with somebody, because I couldn't discuss this. And the next episode after this is going to be a discussion with newborn hospitalists at different institutions, community hospitalists, academic, and other places. And we're going to discuss the practical implications of implementing these guidelines, what difficulties arose and how people got around it. But these were not long. I mean, if you take out the references, the whole thing is 8 pages. The first 3 pages are the intro, and on page like 3.5, you get into the risk stratification and the 3 different potential roads we can travel on this. We can do categorical risk factor assessment, multivariate risk factor assessment, and then, and I'm forgetting the last one now, a newborn clinical condition, which is one of my favorites. And then you get into a little bit of labs, and then the thing is done. The guideline's not long. Was that purposeful to keep it short and sweet so people can really read it and get through it?
It was. I think the AAP and Pediatrics, the Pediatrics Journal, is committed to publishing AAP guidance that has, made all the reviews of all the committees and the final AAP leadership. And they really would like clinical reports to be 3,000 words or less. That's a really tough metric, but for the writers. But I think it's an important one, as you point out, because we're really trying to do things that are practical for practical clinicians who don't, necessarily want to read a tome. AAP also does put out technical reports, which don't have a word limit or a reference limit. And they're different. They're reference documents, and sometimes that is what you need as a reference document. But the clinical reports are meant to be practical.
So quickly, I'm going to go through the categorical risk factor because we all know it, and feel free to correct me if I get anything wrong or add to anything you feel I need. But the risk factors for these algorithms are: number 1, any newborn infant who's ill-appearing; number 2, a mother with a clinical diagnosis of chorioamnionitis; number 3, a mother who's colonized with GBS and who receives inadequate prophylaxis, intrapartum prophylaxis, with a duration of rupture of membrane being greater than 18 hours or birth before 37 weeks gestation. And number 4, a mother who's colonized with GBS who received inadequate prophylaxis but with no additional risk factors. And the recommendations are, if they fall in category 1 or 2 with the infant, to do lab testing and empirical antibiotic therapy. If it's category 3, observation in the hospital, lab testing for category 3, and observation in the hospital for more than 48 hours for category 4, which, we went over in 2018, I believe, the guideline. We went over the old ones right before the new ones came out. And then that really is roughly the same as it was then. Is that a fair assessment?
It is. I think it addresses a couple things. I mean, one is that many times after a vaginal birth, it's hard for a center to hospitalize the dyad for a full 48 hours. There's this sort of 2 midnight rule. You give birth at 10 o'clock at night. And so we did sort of change it to like 36 to 48 hours as, particularly if you can assure good follow-up. But yeah, the categorical risk assessment is old. It's really well defined. You know what you're going to get out of it. And you're going to give empiric antibiotics to as much as 10% of your birth population if you follow it strictly. And the advantages, again, are that it's really familiar. It's pretty straightforward. If you're in a humongous center and you have a lot of trainees, for example, that are doing your primary work, you may feel like it's the safest thing to do. It has a lot of implications depending on where you can give a well-appearing infant antibiotics in your hospital, whether you can do that in a well nursery setting or whether you have to become a NICU or special care nursery admission. I think some of the things that we took on in our work developing the calculator was this issue of, well, you're ill appearing. How are you ill? When are you ill? How long are you ill? What if you start looking better? So it has its limitations, but it certainly is a reasonable approach. I see it as conservative, but that's a value judgment, right? That's not a fact. Right. And if that is what is most comfortable for your setting, that is a entirely reasonable approach. It'll lead to the most empiric antibiotic administration in the newborn setting.
And then the next set of assessment is the multivariate risk analysis, and this was done with a cohort of 608,000 newborn infants to develop this predictive model. The objective data included is gestational age, the highest maternal intrapartum temperature, the maternal GBS colonization status, the duration of rupture of membranes, the type of and duration of intrapartum antibiotic therapies. And this is the neonatal early onset sepsis risk calculator, which you developed and know very, very well. And what I liked here was you talked about it very straightforwardly. Blood culture and enhanced clinical observation are recommended for infants with an EOS risk estimated at greater than or equal to 1 per 1,000 live births. And then blood culture and empiric antibiotic therapies are recommended for infants with an EOS risk estimated at greater than or equal to or greater than 3 per 1,000 live births. And you discussed that blood culture testing declined by 66% and empiric antibiotic administration declined by 48%, close to half with this approach compared to the categorical risk algorithm. So you kind of talk about how it could help and that there was no adverse effects with this versus the categorical risk assessment off the bat.
Yes. When we first started doing this work, and I originally was fortunate to be partnered with Gabriel Escobar and his group at Kaiser Permanente, Northern California, we had some clear goals. Our goals were to find the smallest number of risk factors that we could use and still predict well, to focus on objective data with the idea that ultimately you could integrate this into an electronic medical record. And we really wanted to get away from the clinical diagnosis of chorioamnionitis and really break it into its components, which are usually maternal intrapartum fever or elevated temperature, and often that's interactive with duration of rupture of membranes, which is sort of a surrogate for duration of labor. We collected enormous amounts of data beyond all of that and did ask the question that, does this element make the models better? Does that element make the models better? Does it help if we include the baby's glucose level? Does it help if we record whether or not mother had epidural analgesia? And we were able to make a bajillion models before we settled on the ones that we settled on. And of course, there were like really smart statisticians doing this, not me. And I think that the issue of where you cut it, so where you decide that at this level of risk you do this clinical action, was something we had to do secondarily. And we developed that by holding essentially these special seminars with practicing clinicians in the Kaiser Permanente group. And we sort of went through all of this, all the statistics, et cetera. And we say, look, if we cut it this way, this is what we would predict. And if we cut it that way, this is what we would predict. And, a metric of doing something different at an estimated final risk of 1 per 1,000 means you're looking at essentially double your risk. Your baseline risk is very low. So it's double a low risk. It's still not high. What's reasonable to do at that point? And where do you have to go? where you guys see it as reasonable to give empiric antibiotics. And that was really fun work. We held a couple different nighttime, dinner was provided. I was in by webinar from Boston and just sort of hashed it out. And then, the Kaiser guys really did this. They did a prospective implementation study in the 15 different birth hospitals of the Kaiser Permanente Northern California group. And that was our 2017 paper that we published in JAMA Pediatrics. It said, we did this. Nobody died. We found the same proportion of infants sick in the DR. We didn't find any really significantly different rate of infection. We had no mortalities in either pre or post-implementation. Well, actually, there was one infant in the post-implementation period who had presented profoundly ill in the delivery room and who was treated actually with ECMO and therapeutic hypothermia and still sadly passed away. So we were able to say what you just said, that you could decrease clinical activity, decrease empiric antibiotics, and still safely identify infected infants.
Now, Karen, I have to tell you, I trained in Newark, New Jersey, in what is now Rutgers, New Jersey Medical School. When I was in medical school and residency there, we had some attendings who had been practicing a long time. And one of the things, they were caring and wonderful people who taught me well. But one of the things they used to talk about was how they would say, we used to just monitor infants clinically and look at them clinically. And if we lived at the hospital, if we got worse, we would treat them. And all these guidelines are now coming up. So you have to do this, this, and this. So when I read the newborn clinical condition risk assessment section, it brought a smile to my face because I thought of them and I thought, I hope they read this. They're probably loving this.
So, one of the things I remember Gabriel saying to me is, nobody needs a fancy model if the poor baby in front of you is got APGARs of 0 and 3, right? Clinicians are not stupid. They know what to do when a child is very ill. But what's hard is when the baby's breathing a little fast for a couple hours and then they look okay. Mother, there was an interpartum fever to 102, but the baby is entirely well appearing and, at breast nursing fine. Is it really a baby we should separate from the mother? And so our goal really was just to be able to quantify it all so that you could make a rational decision around a number, essentially, that you could rely on. But I think, again, pluses and minuses. You have to develop structures to do these calculations. And this is not a model that's meant for secondary evaluation. People tell me this all the time. They say, well, we take the babies whose mothers had choreo and then we use the calculator. And I say, well, that's incorrect. This is actually a population evaluation tool. The best way to use it is you do the calculation on everyone. And what you find is that 50% of your birth population actually has an estimated risk at birth that is more than 5 times below their basic population risk. And so it's helpful there too, because sometimes you do have a baby who's a little this, a little that, and it can be helpful to know that their estimated risk of infection at birth is 0.02 cases per 1,000. And that may help you take a bit more time to think about what else might be wrong with them before you just reach for your bottle of antibiotics. But it is a lot in setting up the structures to make the calculation. And you don't have to follow the clinical algorithm that Kaiser put forth and validated. You can decide that seems crazy to you and you want to give empiric antibiotics at a final estimated risk of 2 per 1,000. But you got to do the work to make that happen at your center. And then for the infants that you are putting in nursery, who you used to put in your special care nursery and give antibiotics, you do have to have structure for a little bit closer evaluation. And I think, when we implemented that here at the Penn Birth hospitals, that was the part that was most anxiety producing for folks. To take an infant that used to be a NICU admission for antibiotics and say, no, you're going to stay with your mother in a newborn nursery setting, and we're going to keep a closer eye on you. And if you develop signs of illness, then we'll take some actions. When we first started doing that, people were anxious is the only way I can say it. Over time, it becomes what you do and you are not anxious. But that gets to your third option. maybe you'd like to describe that.
Yeah, so that was the reason for my story, because this one I found fascinating because it's for all infants of any estimation for risk of EOS. They will, if they're going to have it, you describe they're going to develop symptoms over the first 48 hours. And the Italian study had these all infants managed with serial physical exams every 4 to 6 hours for the first and through the first 48 hours. And if they had someone available to examine and act on the child if they looked well or poor, then that decreased the use of lab tests, blood cultures, antibiotics. But this is a labor-intensive option. But this is the one that struck me the most for my
What goes around comes around, right, Tony?
Yes, it really does
So I
seem like
think
that.
the group that has really, at this point, and a couple of these papers have been published since we got the clinical report done, but they're done at Bill Bennett's place in Stanford, so we knew they were being done because Bill is one of the authors of the clinical report. At Stanford, they published 3 papers over 5 years where they said, okay, we're going to take all of these term infants who have been labeled as at risk because their mothers had a clinical diagnosis of chorioamnionitis during labor and delivery, 100% of which at baseline we administer empiric antibiotics. And we are going to simply say if they look unwell at birth, then they will get empiric antibiotics. And if they don't look unwell at birth, we will simply monitor them. And in their first iteration, they monitored them in a special care NICU for 24 hours. And in the end, they went essentially from 100% of that group getting antibiotics to 20%. It was about 10% at birth and 10% developed some symptomatology. In their second iteration, they decided that putting them in a NICU and putting a pulse oximeter on them especially might have unintended consequences. And so they put babies 35 weeks and above in dyad care in their well nursery. They did provide very intensive nursing evaluation for the first few hours with a NICU nurse and then with a well nursery nurse, and had vital signs done every 4 hours, and dropped their overall rate of empiric antibiotics to, again, a group that used to 100% get it to about 11%. And they published a final paper in the past year or so showing that they were able to sustain this over 5 years of implementation. And some of the things they pointed out is they maintain a strict 1 to 3 nursing assignment in well nursery. And those of us who run well nurseries as well as NICUs, and I am one of them, know that that is not always achieved. Let's call it what it is. That's 1 nurse for 6 patients if you think the babies count, and I think they do. But not all well nursery settings are able to achieve that ratio on a consistent basis, and not all centers are able to be doing Q4-hour vital signs on all of those patients for 36 hours. So there's different ways you can use clinical observation. You can decide you're going to just dispense with all risk factors and do it for your birth population. And if you have a small enough delivery service, that might be reasonable. You can decide you're going to start with categorical risk assessment, or you can start with the calculator and you can kind of divide babies out and say, this is a at-risk population that is currently well appearing, and this is how we're going to treat them. And again, the pluses are a lower rate of empiric antibiotics administration, probably about the same as the calculator in the end. A lot of changes to your local structure of care. But the most important divide here is that somewhere along the way, our field made the decision that we or adopted the belief that we could look at every newborn at birth and predict who was going to go on to become infected, or we were going to try. And that if an infant at 7 or 8 hours of age who had initially been well appearing developed some signs of illness and was ultimately found to be infected, that we would view that as a failure. That was a missed case, and that was a terrible thing. You need to change your thinking. And so if you are going to use observation only, what you are saying is that is exactly what you expect. That there's a very small number, probably even a handful over the year, depending again on how big your birth population is, who are going to initially be well and are going to present as ill later in their birth hospitalization. And you're going to have a structure in place to identify them and care for them before they progress to a severe sepsis syndrome. And that is a win, not a fail. And that, I think that is the major reason why there's 3 options in this report, because there is not a clarity among neonatal clinicians around this issue of what is a miss and a fail versus what is a expected outcome of care. The Stanford site will tell you that they have not had any disastrous things. They will tell you that their approach also identifies infants who have non-infectious troubles, and that's important. But I think this is just a place where there is not uniform agreement in the neonatal community, and I respect the fact that people differ on this topic, and this is one of the real areas where groups who are caring for infants in real time need to make a very clear decision about what they think is the best course.
That's fascinating. It's one of the oldest rules. Whenever you do anything, define what you figure out what you're going to call a success and what is not a success. And it sounds like in the neonatal community, that part is perhaps regional.
So Gabriel and I wrote an editorial at one point that I think we called accepting something like accepting the uncertainty of neonatal early onset sepsis. And what I try to say to people is that all sepsis, all infection that needs to be found will be found. Either the infant will tell you at some point, or you will have some other strategy for finding it. Believing that you can identify every ultimately infected infant at the moment of birth, you are fooling yourself. That was not the case in the older iterations of categorical risk assessment. That's not going to be the case with the calculator. And the idea that a child will evolve and show up as ill later on is, again, an accepted part of clinical observation. And I don't think that's a terrible thing. We are the country that has our infants largely in a hospital setting. And the care that we are giving in the immediate neonatal period and in the well nursery setting is real care. This is serious hospital care. And sometimes I worry that a field that's sometimes dominated maybe by neonatologists forget that or fail to recognize that serious medical care is going on in a well nursery setting, and there is a reason for that care, and this is one of the reasons. I will tell you this final vignette, which is that several years ago, shortly after we adopted the calculator here at Pennsylvania Hospital, there was an infant who had a low sepsis score at birth and would not have been flagged by a categorical risk assessment. There were no risk factors for sepsis, essentially. And one of my very experienced well nursery nurse practitioners went to discharge this infant probably around 36 hours of age. And the baby was really tachypnic, and she had seen the baby the day before, and the baby had been well, and the mother told her that the baby just really wasn't interested in feeding all night. And so Allie sent that baby to the NICU and did not send that baby home, and that baby had sort of the last scourge of neonatal early onset sepsis, which is that baby had GBS infection born to a mother who had been screened GBS negative, who had not received intrapartum antibiotics, and who had no other risk factors for infection at the time of labor and delivery. And my nurse practitioner was horrified. She was so upset about this. And she was like, oh my gosh, what if I had sent that baby home? And I said to her, Allie, why do you think I value you? You didn't send that baby home because you've done this forever and you know the difference between a well baby and a not well baby. And this is why you do what you do every day. I am not upset. I am grateful to you for being a really good well nursery nurse practitioner.
I mean, I think that's the perfect thing to say.
We have kept very strict track since 2015 of the infants who have developed early onset sepsis who are born 35 weeks and greater here at our hospital since we've been using the calculator. We have found what can be found. You would predict using the calculator that given that we deliver about 5,000, a little more than 5,000 deliveries a year in a pretty high risk setting, that 2 or 3 cases that we've identified will present later with no risk factors, and that has been the case. The remainder had elevated sepsis risk scores. About half of them were ill at birth, and half of them sort of evolved. We have had no cases of meningitis and no deaths. So we too have been able, we published an interim analysis, but sort of I looked at this recently for a talk I was giving. There are so many lessons in the topic of neonatal early onset sepsis about about medicine, about structure of medicine, about philosophy of medicine, about what we do and why we do it. And I am happy to say that at some point someone will revise this clinical report. That is why medicine's great, right? Theoretically, we're always getting better tomorrow. But I do think that this report has moved the field, and hopefully it has really helped neonatal clinicians think about this topic and think about our goal of keeping babies healthy with doing the least harm that we can along the way.
Karen, I don't know of a better way to end the podcast. I mean, I agree 100% with everything you said. Their generations will come after us to revise these things. That's what happens. We've done our part to push medicine forward. And if nothing else, the innovative model you've created with your partners, Gabriel and the rest of the committee, really gave us a different way, I think, to look at medicine in general, using shared decision-making, using local resources, and figuring it out and combining the old with the new. And we have all these techniques, we have all this stuff where we practice is important to incorporate these. But I've loved this conversation. This has been wonderful. I really thank you so much for coming on. Yeah, I can tell. I can tell. Now, I always give my guests an opportunity. Is there anything we didn't talk about that you...
Clinicians continue to ask me about the use of laboratory tests. I want to say this efficiently. I wish the CBC worked for us. If you are making a decision around the time of birth, the white blood count and its components and its derivatives are not going to work for you. We tried. In work that Tom Newman at UCSF led, we looked at 67,000 blood cultures and white blood cell CBCs that were paired together because we fully intended to integrate that into the calculator models. And there is no predictive value of the total white count, little of the ANC, a little bit of the I to T, if you obtain those laboratory values within 4 hours of birth. There's a lot of reasons for that. Lots of folks have already published on those reasons, but the process of birth affects those measurements, and they are not going to help you predict who is going to get infected, and they're not going to help you make the decision about antibiotics, no antibiotics. The CRP, the same thing. People like to use the CRP. It is a non-specific indicator of inflammation, and around the time of birth, you can have an elevated CRP because you have a big cephalohematoma, because you have a pneumothorax, et cetera, et cetera. Some proportion of infants who are infected would have an elevated CRP at birth, and a larger proportion of infants who are infected will not have an elevated CRP at birth. So the best way of making your fundamental decision, who gets to go to nursery, who needs enhanced surveillance, who needs empiric antibiotics now, should be made using the clinical details of labor and delivery as laid out in the report. If you want to use those laboratory values for other reasons, they function better if you wait till 6 to 12 hours after the time of birth. And none of this is a commentary on their use in a NICU baby or in late onset sepsis or in the evaluation of the febrile 3-month-old in the emergency department. Those are all very different topics and very different uses of those lab values.
Well, and one of the last thing that struck me was, with all of our talk of antibiotic prophylaxis, for some reason I expected GBS not to be the number one cause of early onset sepsis. I don't know why. When I was reading it, I was surprised.
It remains about 50% of interim babies because of the issue of mothers who screen negative who actually are positive at the time of delivery. So that is a persistent problem. It's not true in preterm infants, by the way. Unfortunately, the overwhelmingly dominating organism in preterm infants is E. coli, and increasingly antibiotic-resistant E. coli. So a topic for another time.
Karen, thank you so much for coming on. This has been really pleasant. I enjoyed this so much. I learned a ton. Thank you. Time for our acknowledgments. I want to thank our special guest again. I really do appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh, and specifically the Paul C. Gaffney Division of Pediatric Hospital Medicine, for continuing to support the podcast. I want to take the time to remind our listeners that there is CME associated with most of our podcast episodes, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Please just click on the link at the bottom of the podcast, takes you to a web page, create a free username and password, answer some questions that I write that are not hard, and that's it. You get AMA Category 1 CME credit. I want to, as always, thank and acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. But I really want to thank you all who are listening. Thank you for letting me come into your earbuds or your car, wherever it is you are. I really appreciate the fact that you do that. If there's anything you want to hear or think we can cover better, any comments, suggestions, compliments, whatever you want to do, again, as always, please feel free to email me at tony.tarchichi, tarchichi, @chp.edu. Thank you again, everybody. I hope you have a great day. We'll see you next time.
Thank you for listening.